Hello, I'm Brenda Kong, and my group members are Emily Sanchez, Heaven Murphy, and Angelica Perez. And our presentation is about gender bias when it comes to diagnosing personality disorders. So there's many examples of disorders that are more prevalent in men than women, or vice versa. Some of these examples are narcissistic personality disorder and antisocial personality disorder, being diagnosed more in men, and then dependent, avoidant, and histrionic personality disorder being diagnosed more in women. So we'll each be looking into different reasons on why this might be, and really we'll be talking about narcissistic personality disorder and how symptoms present differently in men and women. Me and Heaven will both cover borderline personality disorder, and I'll cover how symptoms present in men specifically, while Heaven will talk about how they present in women. And then Angelica will talk about antisocial personality disorder and how symptoms present differently in each gender as well.
The sex differences on narcissistic personality disorder. It would appear that men are commonly diagnosed with NPD more so than women. The study examining sex differences in narcissistic personality disorder symptoms helped with uncovering the gender-based disparities in the disorder. In the study, researchers performed an audacious interview with roughly 35,000 participants with an estimate of 20,000 women and 15,000 men. Each of the participants were interviewed on the 9 symptoms of NPD. Those who received the diagnosis had to have at least one of the symptoms that caused social or occupational dysfunction. For the symptom, lack of empathy, men scored 9% and the women scored 4.6%. For the symptom being envious, women scored 4% and men scored 3.2%. And for the symptom sense of entitlement, men scored 6.8% and the women scored 4.0%. It is important to note that even though there were more women than men in the sample size, 7% of men received the diagnosis of NPD, while only 4% of women received NPD. The conclusion made from these findings was the result perhaps reflected sex bias in diagnostic criteria, but are indeed consistent with recent views of NPD being conflated with symptoms that are specific to one's sex. Perhaps adding symptoms that are more reflective of how women are socialized in society may give better accuracy to women getting diagnosed with NPD. Looking at the gender disparities in NPD, the same could be for BPD, where men show more of certain symptoms in the disorder, while women show more of other symptoms.
So, as Emily mentioned, I will be looking at how symptoms of borderline personality disorder manifest in men specifically, how that might affect them getting a diagnosis. So, I found an article and a study where they took a group of 511 people, and each of these were split into 4 different groups. 2 of them were controls, one for men and one for women, and then the other 2 were for those that were diagnosed with BPD, and they were also split by gender. So the actual study that they did involved giving each of the participants a variety of tests that were graded on scales. Each of these measured a different trait, and these traits were impulsivity, aggression, affective lability, severity of depression, and social adjustment. After running these tests, they found that the men with BPD had higher scores for impulsivity and physical aggression. So looking at these results, we can make a couple of inferences on why men don't get diagnosed as often. So one of the major roles would probably be how society typically views and perceives men. Seeing a man being more aggressive may be considered normal and not something that would be worth raising concern over. And there's also the fact that society tends to put a heavy weight on the concept of masculinity. And typically, seeing any type of vulnerability or weakness in men is frowned upon and oftentimes ridiculed. So that could be a factor that leads to men even just being deterred from seeking help. And now we'll have Heaven, who will be presenting how BPD symptoms show up in women.
Yes. So my case study differs a little bit from everybody else's, whereas the participants are not individuals that have the symptoms, but rather the case study focused on professionals who were given the task of diagnosing randomized case studies. So they were trying to detect whether or not clinicians showed a given bias based on genders when presented with patients with exactly the same symptoms. So they had 4 options between case studies, with some cases with women having BPD or ASPD and males having BPD or ASPD. To make the study a blind study, they also gave every participant an extra case study with schizophrenic diagnoses to rule out poor diagnostic skills. They hypothesized that women were more likely to receive a BPD diagnosis than males with identical symptom presentation. There was 72% correct diagnosing of BPD in females and 78% misdiagnosing males with ASPD that actually had BPD. So some of the factors that may contribute to the idea of women being diagnosed more frequently with BPD than males is it could be dependent on the clinician's gender. So women are actually more likely to diagnose other women with BPD. And sometimes BPD can be misdiagnosed with PTSD from childhood traumas or sexual abuse, and women tend to have 10% higher rates of childhood sexual abuse. More socially acceptable for young males to show signs of aggressiveness, anger, and sexual impulsivity versus women. So those are more normalized. The strong presentation of aggression and masculine behaviors in BPD directly collides with the diagnosis process that is discussed in Angelica's case study on the presentation of symptoms of ASPD with regards to the male gender.
Hi, I chose a case study with 323 participants. 253 of them were men and 70 were women. All of them were diagnosed with ASPD. Screenings were required for each of these participants to be evaluated, as well as providing written consent that they are allowing further research to be conducted. Aggression, impulsivity, and childhood trauma were evaluated in a severity scale. Aggression was evaluated in a scale of occurrence throughout the patient's life, as well as the presentation of antisocial behaviors such as police involvement or suicidal tendencies. Underlying emotional abuse became extremely prevalent in participants that presented ASPD. That includes varying forms of emotional abuse, neglect, verbal abuse. Both male and female patients both presented comorbid presentations such as substance abuse, other diagnoses. Female participants do not present as many antisocial behaviors and have less interactions with law enforcement in comparison to the male participants, as well as the female participants scoring higher in the childhood trauma questionnaire, as they did present more emotional and sexual abuse. The findings also found that ASPD presented in both genders, but they could also be placed in subtypes of this disorder because they are not approached in the same way. Our findings indicate that the treatment of individuals with ASPD should focus on the following: management of the comorbid substance abuse as well as disorders in both men and women. Prevention of antisocial acts is more important for men, as well as management of mood is more important towards women. To summarize all of these findings, Ember Lee's case study presented a study on the disorder of NPD. Although this case study was quite large, the male participant size was substantially higher than the female participants. Therefore, the male presented much more symptoms that align with this disorder. In Brenda's case study, there were 4 groups presented. 2 of them were control groups with both a male and female party, and 2 of them were variant groups with BPD presented in both male and females. They were both clinically tested with surveys and questionnaires to evaluate the symptoms. Male presented much higher scores regarding impulsivity and physical aggression. In Heaven's study, clinicians were given case studies with 4 diagnosis options. Comparisons of these case studies regarding genders and symptoms present. Different factors or disorders were placed into the case study to prevent issues with further research. Moving forward, Heaven's going to be presenting our clinical questions and our applied valued findings.
Yes, so all of our research kind of shows that there is, in fact, a gender bias among clinicians and how this is kind of a widespread problem. I think the research our group has done advocates for a change in the way that clinicians give clinician objectivity. In general, women are often seen as more emotional and they tend to score higher in rates of neuroticism. Therefore, this can sometimes be a reasoning behind the high rates of misdiagnoses in personality disorders for women. As Emberly mentioned earlier during her presentation, an important factor that could alter these disparities is assessing more women with these diagnoses and reflecting their symptoms throughout the DSM criteria to be more representative of both genders. In the majority of our presentations, I think we all almost address that males showing signs of aggression or impulsivity is more normalized than a woman showing the exact same behaviors. So society has found a way to normalize bad behavior from men, but make it seem irrational for women. And this can sometimes correlate with the way that clinicians perceive things. So showing these articles and case studies, once again, it just emphasizes the control and holds that societal standards have on not only society, but clinicians' point of views. So overall, these findings show the unfairness in the world of diagnosing personality disorders. Moving forward, Emberly is going to present our next questions for future studies.
Finally, the questions portion of the presentation. It seems that there are many disparities amongst the differing personality disorders, ranging from women being commonly diagnosed with BPD and men being commonly diagnosed with MPD and ASPD. Some questions for further research may be, are the way men and women socialize in society contribute to their likelihood of receiving a particular personality disorder diagnosis? Does early childhood trauma contribute to the onset of personality disorders? Also, what symptoms can be added to the diagnosis that represent more of how men and women display the disorder? For instance, women may display behavior that represents a lack of empathy for MPD, but wouldn't consider their reason for the behavior as lacking in empathy, and men may have fear of abandonment, but will not be aware of this being the reason for why they're angry. Overall, it's fair to say the socialization of men and women may play a role in how one gender is diagnosed with one disorder over the other, and should be further expanded on. This concludes Group 18's presentation for gender disparities in the personality disorders. We hope the information was entertaining and enjoyable to hear. Thanks again.